Today on A Hit of Health.
Basics of a ventilator is the ventilator is the machine that helps you breathe. Tons of different settings that we use to help oxygenate people, get oxygen in their blood. The sickest people are getting ARDS right now from COVID. So I guess that's one of the big reasons people are ending up on these ventilators. What are the treatments and stuff like that? And it's still, there's so much that we don't know. And they talk about on the news that it's not bullshit.
5, 4, 3, 2, 1. We are live right now. Okay.
Hey.
Yeah, please. So, so here we go. It's March 27th. We're talking to Kevin Eleazer here, and we're talking about COVID. I'm gonna let Kevin introduce himself really quick. Him and I go way back. Looking back from today, a shockingly far time back. Actually, it's funny to think about.
It's been a while that we've known each other.
Dude, it really has. All of our time together has been pretty damn wild, and this is
it has.
And this is no different. Okay, so Kevin, please introduce yourself, who you are, what you're doing, and then let's jump into COVID and what the hell this thing is.
All right. My name is Kevin Eleazer. I am a critical care nurse. Currently, I am working as a travel nurse, traveling around the country on contracts with different hospitals. And I am in Richmond, Virginia at the moment during this wonderful COVID crisis, working in ICU out this way.
Man. Okay, so crazy. First of all, crazy. Traveling nurses, that seems just like... Well, I feel like
yeah, we've talked about that,
dude.
As well.
Man, what was crazy is, I mean, what's just one curiosity question? Have you seen wages increase right now for traveling nurses?
Yeah, so they have. It's crazy because I just had signed on for a new one at my hospital I'm currently at, but right after, about a week after my contract would have ended, they started doing, they're called crisis contracts. Typical contracts about 13 weeks. These ones are 8 weeks, and I think the highest I've seen, it depends on the company too, because the companies have overhead that, I work with, my management company. But, you're looking between $5,000 to $8,000 a week in some places.
Yeah, that's fat. That's so fat.
That's ridiculous.
That's so good. So if you're listening and you're thinking about medical school, go to medical school.
Yeah.
At least nursing school.
Yeah, nursing, yeah.
Right. Okay, sick. Okay, so crazy time. Cool time to be a nurse. Okay, so question, and this is, before we were talking about, we were going to do something else, and then this kind of came up about what's going on in the hospitals, and it just is so freaking interesting to hear primary source information instead of going through CNN or all these, freaking people with an agenda.
Sure, yeah.
Right, and so what was interesting, the first thing that was so interesting is, like, I just didn't know, like, obviously the thing is all these, the Cuomo talking on the news about getting ventilators to New York and, all this shit about ventilators. And so the question that I'm curious about is, like, what does a ventilator do for a patient, A, without coronavirus, and then B, with coronavirus?
Sure. And, it's one of those things, I think we all have a picture of it in our head from whatever, insert medical documentary / show here, what it is. It's the tube that comes out the mouth to a machine, right? And that's basically what we know. What a layperson, at the very least probably sees. So what the basics of a ventilator is, the ventilator is the machine that helps you breathe. So ventilators work differently. Tons of different settings that we use to help oxygenate people, get oxygen in their blood, which isn't always the only reason we need it. Sometimes the person can't, we say, exchange air, which means to kick everybody back to some bio class back in the day. Oxygen goes in through the lungs and CO2 comes out through the lungs. So sometimes you can't get the CO2 out, and that's another reason we use a ventilator. It's basically the finest tuning you can do that lets us really tweak a lot of settings, from how much air we put into your lungs to how fast you breathe, for how long that air stays in the lungs, to give you an option, time for it to exchange. So basically, though, your run-of-the-mill person is gonna experience a pretty critical event that will cause them to need to be on a ventilator. They stop breathing completely. They have a cardiac arrest, so their heart stops. Or they have terrible infections or fluid in their lungs, which can happen from various stuff like heart failure. But they're real emergency situations anymore, typically, that you'll end up on a ventilator.
Right. This is not like my lungs hurt, I'm going to the doctor, I'm getting put on a ventilator.
Right. No one leads off that way.
Okay.
It's a lot of time because we have a lot of other stuff. You hear about like a CPAP that people wear at home to sleep, to help with sleep apnea. Mm-hmm. We have big boy versions of those called BiPAPs, and we can that's the kind of the last stop before we put a tube down your throat. But it's still a mask, and they work great in patients that a couple of years back, more than a couple of years, but we would have normally had to put on a ventilator. We can use the BiPAP now, and it's non-invasive. Mm-hmm. But people with the coronavirus, what's happening is they're experiencing typically real bad respiratory distress and going into what's called acute respiratory distress syndrome, or ARDS, which pretty much 100% of the time you can go into. So this is its independent thing. So the virus, COVID, or coronavirus 19, is causing such bad inflammation and fluid buildup within the alveoli and lining of the lungs that you can't get air in or get CO2 out. It's an emergency whether COVID's causing it or something else is causing it. It's not that common. But as a disease as a whole, but the sickest people are getting ARDS right now from COVID. So I guess that's one of the big reasons people are ending up on these ventilators. Right.
So it's not like you go in, you say, hey, I'm having a hard time breathing. You don't automatically say, you're having an acute respiratory distress syndrome. And you're not automatically put on a ventilator. It has to get to that point. So what does that path look like? Okay, so all of a sudden I'm sitting in my room watching TV. I'm all of a sudden sort of short of breath. I'm like, this is kind of weird. I go to the doctor. They're like, oh, you have coronavirus. And then what is that path to all of a sudden now I'm on a ventilator? What happens in the body?
So often what's happening, we're thinking, a lot of it's still theoretical. You and I were talking about, why this person versus the other person, why are all the, what are the treatments and stuff like that. And it's still, there's so much that we don't know. And they talk about on the news, and it's not bullshit. There's a lot of stuff that they don't know why this virus is affecting people worse than others, what it's triggering within the body. Some of the big theories right now are that it's creating a hyperinflammation state. And as we go through this interview, I'm going to keep trying to remember what it's called, because one of the pulmonologists at work was telling me about it the other day.
I have a Google machine if you need. Let me know.
Yeah, that's what I was. Cytokine storm. That's what it's called. Cytokine storm. Yeah, is what they're saying. But
cytokine storm. Yeah, right there.
Yeah. So CYTOKINE storm. So it's basically like this hyperinflammation state that seems to really be, they're thinking, is being triggered by the virus. As to why or how, I'm sure there's a lot of very detailed stuff about that. But long and the short, the treatment for it's not typically something that's experienced with an infection that we're used to. You're normally going to see this with rheumatic disorders, which kind of just inflammation disorders that aren't typical, and you're not even going to go to like a normal doctor if you have one of these things. You know,
Wow.
you're going to go to a super specialized doctor.
Okay.
So not every, you know, the fact that your body's getting so inflamed that the lining and area, they're called alveoli within your lungs, the little air sacs where the blood air exchange happens. You get super inflamed and fluid builds up within there. So it can happen acutely, it can happen more slowly, but basically what it's looking like is people get into this, you know, they get their cough. Typically you're going to start with cough with COVID. You know, they say monitor your fevers and all that, but really you're going to have a cough a lot of times first, and then you'll get a little feverish. And then it'll build up to where you just feel like, you know, you'll have this kind of tightness. You feel like you can't breathe well. You start breathing quickly, and then you'll breathe more and more quickly. And that's your body's response, trying to get more air into your body. Problem is, the air's coming into your lungs. It's just not getting into your body. So you'll lose more oxygen. It's kind of insidious in that, you know, your body's got to keep trying to work harder and harder to breathe. You're never going to get, you know, you're not exchanging the oxygen to begin with, so you're actually using more oxygen, trying to get more oxygen that's not going to get into your blood. So eventually these people either stop breathing or, you know, hopefully they're at the hospital at this point. And we realize we need to intubate them, which is when we put the tube down there through their mouth into their windpipe. You drop that tube down there. There's a little balloon, we call it a cuff, around the outside of that tube that we inflate, so that just then totally blocks off that air pipe. And the end of the tube extends beyond that. So that gives us total control over air in and air out of the lungs. Then we hook them to a ventilator.
And so
you're on the breathing machine.
Right, and then you're on a breathing machine. And then, so now, one thing that we had talked, so two things. The first thing is, does it stop? Can it stop before it gets to that point? Like, are we seeing that? Are we seeing it stop before it gets to the point where you you literally can't breathe?
Yeah,
Okay.
Definitely.
Okay.
The vast majority of people, like they were saying, some people show no signs that they're either infected, other than, you know, they might not even really have a cough. They might just have a sneeze and got tested randomly. Like I was that NBA player's name, totally forgot. But he was essentially asymptomatic, and so that's the most extreme version where you end up there. And I think that's still, we're looking at a mortality rate, I think, right now. So how many people die from COVID right now is less than 5% still, I think I want to say. I think we're above 3, though, where we were thinking back when it started in China. I think it's slowly working its way up, but it's less than 5%. So, you know, that's a lot of people that are getting sick that aren't getting to that point. And I would say, I think typically what they're seeing is people have, they say, like a bad flu reaction. They're saying that it's flu. To me, it sounds more like me personally, anytime I've had the flu, it's a body aches, but I don't have a lot of wheezing or difficulty breathing with it. And this is a respiratory, it heavily affects the respiratory and lungs on everyone. So that's why you get your cough and stuff. So I'm thinking, I don't know for a fact, but I would think it would be more like a really bad bronchitis or upper respiratory infection, where you might have at the max a little difficulty, little tightness or breathing stuff, but you don't have to come to the hospital. One of the reasons people are getting admitted now is if you come to the hospital and you need oxygen, so you don't have enough oxygen in your blood, even if we're just throwing you on those little nasal prongs, those little baby ones, and giving you basically 2 liters of oxygen out, or minute, I think, and that's pretty much the lowest we ever give. That's still a drug. Technically, oxygen's considered a drug, and so you have to be admitted.
Okay.
But there's plenty of people that are positive, and they don't end up even on, like I was saying, like a BiPAP or one of the really heavy hitters beforehand. But they might need, some, a decent amount of oxygen for a few days. That's going to send them in, and they need to be admitted for that. But definitely, it doesn't always end up in that.
That's where it could go.
Situation.
Right. Yeah. And then most people are not getting to that point.
Right.
Okay. Cool. So that's the deal. So if it gets to that point, what happens is you get put on a ventilator, and then ARDS. If that becomes the situation that you're in, having acute respiratory distress syndrome. That is an extreme situation to find yourself in. Way more likely than not, it's not going to get there. So it's just, It's sort of like, it's just freaky that it could get there. That's, I think,
it is. It is. I mean? And it's a big deal. You and I were talking about even for, the people they're seeing that really are dying from it ends up on ECMO, which is where we basically take the blood out of your body, throw it into a machine continuously, and put oxygen in it, and then put it back in. It's pretty bizarre. ECMO, if people want to look it up. Extracorporeal membrane oxygenation.
Nice.
is what it's called. But yeah, I mean, it can go beyond a ventilator even, and it's freaking. Those are the sickest of the sick, and those are like extremely high chance to get die, something like 90 or over %.
Right. Yeah. Okay. Well, freaky as that is,
there is a final form.
Right.
That's what I'm saying.
not to, but not to glorify it.
Yes.
Oh, jeez. Okay. Cool. Okay. So cool. So there's no. Okay. So that's just. So I mean, that's what you're looking out for. It's like now. Now, when we talk, just out of curiosity, when we talk about shortages in bed space, I mean, if you find yourself in a situation where you have acute respiratory distress syndrome or you're on ECMO, I mean, regardless of if COVID was going on, those would be, ICU situations. Is that correct?
Yes.
Okay.
Someone that's freshly intubated, needing a ventilator, right off the bat. In every hospital I know, you end up in the ICU. There are units called step-down units that can take ventilators, but typically they call them stable vents. They're going to be below a certain % of oxygen we're giving the person, and normally they're been on the ventilator for a couple days. So yeah, if you're on an ECMO, you're not only in an ICU, you're normally in a specialized ICU to take that type of machine.
Just out of curiosity, I mean, in normal situations, when the media hasn't hyped up this virus, I mean, it's a bad deal. Let's be real, but it's a bad deal. Obviously, if you haven't been following, it can kill you. But but at the same,
of you just joining us,
right, exactly. Those people who like to skip ahead. The situation where somebody comes into a hospital, I mean, how common is it for a hospital to be full and then somebody comes in who needs one of these intense, ICU type level treatments, and they can't get it? I mean, does that, you know what I mean? Is that
right? Like before the outbreak?
Before the outbreak.
Or is that what you were asking?
Yeah. Well, I mean, how? Because that seems to be the thing, is like there's not enough space. The hospital, we don't have enough hospital space. I mean, what would happen under a normal situation if somebody came in and needed this kind of treatment? Would they kick somebody out? I mean, what? And how often would that even be a problem?
Yeah, hopefully, the thing is, a lot of times what will happen is you have these, at least, so my background, I worked in a cardiac ICU in South Carolina at a big, level 1 hospital. So we had a lot of beds. And what would happen is the ICUs would fill up. And if something came in that really needed ICU, you could get floated to an ICU that wasn't the specialist. So like I said, I worked cardiac, but we might end up taking like a neuro patient, someone with a really bad stroke, if there weren't beds in the neuro, so you can have these overflows. But what typically would also happen is, if it's during day shift, of course, I work nights, they can get in contact with the doctors much easier and be like, all right, you need to go through your people again and tell us which ones can go where. And basically you do that down the line. So you're sitting at the ICU, but then administrators are talking to the step down units. They're talking to med surge floors, other floors that can take certain types of patients. And we call it making a bed, so yeah, you'll make a bed for these people, one way or another. Someone's moving out of the ICU, or, you have, there's a lot of, we don't go into too much, but yeah, sure. Like a lot of times they would make a bed for this patient.
Cool. And something that was interesting is you had mentioned you had known somebody who was working at a hospital who they didn't have very many cases of this. I mean, would the situation ever arise where, it's the question is there, do you think there's enough space for if,
right.
You know what I mean? I mean, obviously we're containing it, which is why we're doing what we're doing. But with that in mind, let's not even go into the horror shit show that would be if we weren't doing that. Let's not even. But right now, contained as it might be, would you say that, one way or another, people are likely to get treatments? I mean, are we that prepared?
So when we've been what's the big buzzword for it? Flattening the curve. That's the whole idea is that it absolutely can come to a point where throughout the entire United States, we don't have the critical care beds we need for these patients, if everything happens at once. Now, flattening the curve doesn't mean that people aren't getting sick. It just means less people are getting sick all at once, and that was the goal. We can get people turned around off a ventilator out of the ICU in time to have someone else. Now, what we saw in Italy is that was not the case. You had, I think, they were overflowing. Well, they ran out of ventilators. So someone was telling me, and I haven't verified this or looked it up, but, I was like, well, what the hell were they doing? Yeah, I can't imagine not having that option, because that's the only option. There's not, you can't just, ECMO's super rare. You can't just jump to ECMO.
Okay.
And you pretty much need a ventilator if you're doing ECMO anyways. So, so yeah, we could run out of room. We definitely could. I think New York has run out of room. They're running out of ventilators. They needed something. I think they're requesting 20 or 30,000 more, which is crazy to think that, that means in these hospitals, what they're doing is converting other units that weren't initially ICUs. They're converting these units. And that's why, people in my field, the critical care travelers, that's why those contracts have gone up so much, because they're making room in the hospital for the sickest patients. But the matter, if you don't have the staff or the equipment, you can't really fill those rooms with anything other than, bodies, literally, probably dead ones at that point. What do you do? Whereas if your hospital's full before this crisis, you divert the patient if they're coming in. You divert them somewhere else that has room and the capability to take care of that patient. But if that's your, I can't, my heart goes out to New York City right now, all of New York, but New York City's unreal. I have actually 2 nursing friends there, and they are just, I was telling you how stressed out I was taking care of one, and they're talking, their entire unit of 20 plus people are all positive, and they're walking around with a lack of gear, and it's unreal, man. So yeah, we could definitely run out of room. As of right now, they're like, my father, who works out in Salt Lake City, and he's a MD. He's working at the VA right now. Their protocols are all in place. They're working from doing a lot of telemedicine and stuff, and they're ready to go. But he's like, we just don't have. We're not full up at all. Like, we have our entire, he's like, the whole COVID area we made is pretty much empty. I was like, oh. Yeah. So either they've got a sleeping tiger out there, or, they're getting lucky or obeying all the social distancing rules better.
Yeah. And so, it's that thing. It's like, okay, so look, for everybody, and I didn't know this either. A lot of this is news to me too. obviously, and that's why Kevin's here. So, I think that it's so easy to be like, this is hyped, and I'm definitely guilty of that. But at the same time, it's like, look, if you're listening to, we are listening to, these symptoms, what the treatments look like, how intense they can be. And it's not a joke. It's like we're doing this for a reason. It's not crazy hyped. It's a real threat.
Right. And that's
real threats.
I think the big thing to start was a lot of people our age were like, well, it's not deadly to me. It's not going to kill me.
Right.
The problem isn't that. The problem is the thing's virulent as hell. Like, so it doesn't. The biggest age group in the country now is me and your parents' age. We're in our 30s, and the baby boomer generation are essentially the elderly now, or what we would consider, kind of 60 plus, and that's the highest risk age group. Although we're seeing now more and more younger men especially, getting sick and really, really, really sick. So, it's as this thing's gone on, we're seeing it's gotten a lot more real quick, like you were saying. And it can get bad really quick. And the problem is, okay, so we have, let's say you get 500,000 cases, and this thing has less than 5%, killing less than 5% people. But do the math. That's still a shit ton of people.
Well, right, exactly.
Killing. And the biggest, and we don't have you can't ship people states away just because they have ICU beds in Salt Lake City. It's not like the people in New York can send their patients there. It doesn't work like that.
It doesn't work like that?
A bunch of, you have that percent mortality, and you have where New York went from, I think they went from less or around 1,000 to 5,000 in 24 hours, positive cases. And then the amount of people that are really sick there, that's the thing. It doesn't seem that bad when you take it on as, hey, I'm a 30-year-old, generally healthy person. Right. It's not that bad, but this is a social thing. This is everyone. Right. This is humanity. This isn't just me. Right. And I think there's a lot of I won't get into.
No, I know. we can go philosophical if we need to. Let's not for now. All right, cool. All right, dude. Well, that's so crazy, man. It's so insightful to hear what you're talking about, what you're seeing, what your peers are seeing. If I'm a normal, rational person, I'm keeping my ass inside for the time being. So,
practice. When you can, practice social distancing. And when I say when you can, just fucking do it.
Right.
Pretty much you can.
We're talking about that. It's not a suggestion.
Yeah.
Right.
So,
cool, brother. All right, I love it, man. I really appreciate it. Let's reconvene later. We got some more stuff to talk about down the line, but really appreciate you talking about this for the time being, man.
Yeah, man. Always.
All right, brother. Talk to you soon.
All right. Yep.